Well, thank you again. I'm so pleased to be able to join you, and that last talk was amazing. And it's funny because the thing I was doing just before I came in here was to review grants that are looking for early detection signals. So this is actually very apropos, and congratulations on your work, and really looking forward to see how that pans out. These are my disclosures. So I'm going to talk a little bit about this DNA damage response pathway. So this is kind of the origin of why we're so excited about where PARP inhibitors fit in the treatment paradigm for patients with ovarian cancer. But you can see that on this slide, there's a lot of processes that the body tries to conserve to make sure that we all stay healthy. And so some of these defects are relatively easy to fix. For instance, a single strand defect has a template from which it can read for its repair, but double strand breaks can be more catastrophic, and the body has developed a number of strategies to help deal with this, so that we all, as I mentioned, stay healthy. We also try to leverage that for treatment because we'd like to break the cancer cells but keep the normal cells intact. And so we've been focusing on this process of what we call homologous recombination for some time in ovarian cancer, because we know, if you look at the panel on the right, that there is a high rate of aberration of the genes that regulate this pathway. And I've kind of put the chemical signatures here on the left, so you can kind of go back and forth between these two. But you'll see, for instance, BRCA1 and 2 alterations are important because they regulate a couple important pathways in this process of taking a double strand break, that's what DSB stands for, and turn it into a fix. So because if we look at a sample ovarian cancer tissues, we see that there is a frequency of these changes that then actually kind of amplify the opportunity to take advantage of this process in treatment. And the way we've done this, and you've heard of this term, PARP inhibitors, has been to try to promote in a cancer cell the vulnerability that might exist there, so that the cancer cell dies under this selective targeting. And I'm going to just use a really oversimplified graphic, but I think it's illustrative. So as I mentioned, when there's a damage in a portion of the fragmented DNA, there's only 4 proteins here that actually kind of link up to form this double helix. And so if you know what the partners are here down here, it's relatively easy to fix this specific defect. So what we've done is, if we inhibit PARP or trap it on the DNA, it leads to a statistical probability that under replication, there will be a more catastrophic break in that DNA. Now, in normal cells, this process that I showed you on the last slide gets recruited into the system to try to fix this. And the way that this is kind of a complicated process, but what I'll tell you is that because we have 2 copies of every one of the genes in our body, this particular break in DNA can be recovered by looking at the normal chromatid, the normal sister chromatid to this gene, and it reads one layer of that chromatid to form the template, which then can be used just like it did up here, where we know what the partner is, and so we can fix it. So that's called homologous recombination, high fidelity, but labor-intensive process that normal cells, can leverage to survive. So when we talk about a cancer cell that has some kind of aberration or deficiency in that process, we then kind of selectively, target that with this kind of concept. So if you think about a cancer cell having 2 abnormal copies of those genes that I was just mentioning, there is no good way to fix this defect. And so that can lead to cancer death. So we had this kind of selective normal cell survival, cancer cell death. And so we've been really excited about this. But as you can tell from this, kind of like I said, oversimplistic example, we need 2 things. One, we need to inhibit this process so that this happens. And then we need this condition to be present so that it can't repair. Okay, so lots of people say, well, I gave this drug, why doesn't it kill the tumor? Well, again, it has to be in the context of a inefficient repairing process called homologous recombination deficiency. Now, we've demonstrated this in the lab, and I love to tell the story because it's happened so quickly. And some of the some of the brainchild behind all this is actually on this call. So it's really great to have such a great esteemed group of investigators to present to you today. But you can see here that what we did in this lab experiment was we looked at cells that had a deficiency or presence of BRCA genes. In this particular example, they were looking at BRCA2. And what you're seeing here is that what they're doing on the bottom is increasing the concentration of a PARP inhibitor, and they're looking at whether or not the cells survive. So you can see here, as we increase the concentration, the cells are alive, 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 and then all of a sudden they start to die. And this happens when you have very high doses of drug. But in the absence of this kind of process being intact, so here you have both losses of this particular gene, the cells, survive at very low doses, but when you get up to relatively lower dose, we start to see that it's becoming cytotoxic to the cancer cell. And that means that and you can see it's about 1,000-fold shift to the left here of sensitivity in the presence of a PARP inhibitor for this. So this was in 2005. Now in 2009, so just 4 years later from the dish to the patient, we already have a report in the New England Journal of Medicine that shows that there may be some value to this to patients. Now, why was it published in one of the highest profile clinical journals in medicine? Because it produced responses in the phase 1, in the dose escalation, using an oral formulation of this drug in the capsules. We found that patients who had sensitive disease, resistant disease, and even refractory disease, we were seeing some responses to this particular drug. So we were very super excited about this new asset coming into the clinical domain. So 2005 discovery, 2009 first phase 1, and then the gates were off. And we have all kinds of development. I'm just going to share with you kind of high level of what that is, but this is another paper that showed looking across many different tumor types for patients who carry a germline mutation in BRCA1 and 2 exposed to a PARP inhibitor, in this case, olaparib. And you can see that there was a response rate of over 30% in this patient population with a range that was much higher than our expectation for chemotherapy. We also saw this similar effect in patients who were not only just germline carriers for BRCA, but also had somatic or tissue-based BRCA mutation. This is the rucaparib study, and Liz Swisher, who's on this, was very instrumental in getting this program actually up and going, not only the protocol, but the whole program up and going. So we're so blessed to have her on this call. That looked at rucaparib in this space, and we found a very high response rate in patients who demonstrated platinum sensitivity. So again, these two trials were taking patients who actually had cancer that was visible, and we gave them the drug and they made them smaller. And then we extended this even further into another cohort of patients who were based on a condition we call homologous recombination deficiency. Now, I talked about this from the standpoint of mutation to BRCA, of the BRCA in terms of its governance of homologous recombination across the genome. And what we see is that when this particular tumor has an aberration in the function of BRCA protein, that we find that there's this kind of genomic-wide loss of heterozygosity, which is a term that we use to talk about this process that might reflect aberrant repair of DNA. And so what we find is that there are conditions where the tumor is actually wild type for this gene, but still have this kind of signature. And that can be distinguished from the same types of tumors that are wild type for BRCA, but do not have this signature. And so the hypothesis was that maybe these types of tumors could still respond to a PARP inhibitor because these types of tumors responded to a PARP inhibitor. And so we've developed a test now to separate out the loss of heterozygosity high versus loss of heterozygosity low. And we use that as and there's a number of different ways that we can test this. We call this homologous recombination deficiency versus proficiency. You'll hear that term. And these are based on a test. And what we showed in the Ariel 2 study, as well as in the QUADRA study, which is the third PARP inhibitor. So I talked about olaparib first, rucaparib, now niraparib, was that we saw that there was efficacy in patients, you can see again, who were whose tumors were BRCA wild type, but they carried homologous recombination deficiency. So that hypothesis seemed to make sense. And so although these came over a period of about 6 years, we did evaluate this concept in a what we call switch maintenance strategy. So initially we were focused on patients who actually had the biomarker BRCA, and we were using it for treatment like we would chemo. But because it was active here, we moved it forward in a maintenance strategy where patients were enrolled onto a trial if they responded to this chemotherapy, in this case, platinum-based regimens. And if they got a response at this point, we randomized the patients to standard of care, which would have been observation, versus the PARP inhibitor. And so the idea was to take these responding patients to platinum and see if we could delay the time to progression by using something else in between. And voila, you probably all know this, we were successful. And we were most successful, obviously, in biomarker positive patients, but even in the patients that did not have the mutation in the tumor for BRCA, we did see some benefit. And so what I have listed here are the median values in months. And I realize that for some, this may not be, it may be a little bit difficult to understand, but let me just put this into context. So a hazard ratio of 0.23 means that there's an almost 80% reduction in the probability of an event, in this case, progression. And that probability exists on the first day of treatment, because this is reflecting the reduction in that risk of foreign event across the entire exposure of taking the medication. So I kind of emphasize this because it's really important for people to not minimize efficacy when we find that there is a statistically significant improvement in a reduction in a hazard on a clinical trial based solely on the basis of how much different there was at the midpoint of those curves, which we call the median. So here you can see rucaparib in Ariel 3, again, another trial that Liz and I work on together, Niraparib, which was in the NOVA trial, and olaparib, which in this case was Solo 2, but was added to other trials that showed some merit. So a question came up as we've gotten so excited about these drugs in the recurrent setting. They were then moved on into the frontline setting, and you've heard probably significantly that there was an enormous impact in the frontline setting as well. And so it raised the question, what if they got it before? Could they get it again? So we've had a couple looks at what are what would be considered our approaches for patients who have recurrent disease. So one of the questions that comes up frequently is that if we use a drug like bevacizumab or Avastin, if we use a drug like that in the frontline setting where it is approved, could we give it again? And would that prior exposure mean something negative or positive to the patient? So we didn't have any great data for a long time because most of the studies that were done in the recurrent setting had been in patients who really didn't get Bev in the frontline setting. So this particular study, MITO16B, was done to address that question directly. So everybody who enrolled on this study had the bevacizumab or the Avastin in the frontline setting as part of their treatment. And then they were randomized here, in this case, to chemotherapy plus or minus bevacizumab. In this case, it was gemcitabine and carboplatin, drugs that you've probably heard about. And what it showed was that there was a difference that was similar to what we saw in the previous trial, where we did the same exact experiment, but without prior Bev exposure. So we felt very comfortable that the Bev after Bev was a viable concept. Now, with respect to PARP, we were more concerned about this because of the selectivity that PARP, as I mentioned in terms of mechanism of action, that PARP would bring to the table with respect to efficacy. And this is a study that I know both Liz and I were very proud to participate on, that looked at the opportunity for PARP retreatment if a tumor had been previously exposed to PARP and progressed. So what you see here is that patients that did not have a prior PARP, this is the kind of their progression-free survival for going on a PARP inhibitor. But if they had a PARP inhibitor before and progressed on it, they were unlikely to respond. And so that aligned with our thinking, because why do tumors become resistant to PARP? Well, if it restores the machinery that we were targeting, then it would make sense that they wouldn't work. But breaking news, this morning at 7 o'clock, we had the first paper to address a slightly different question. And that was, if we treated patients with a PARP inhibitor before, but then retreated them after a time period, and they re-responded to platinum and gave them a PARP inhibitor again in that next line of therapy, was there a difference? So in this particular, everybody had a PARP in a prior line of therapy. They were then, if they're broken down into two cohorts, a cohort where tumors were had a mutation in BRCA or were not, and then they were randomized to olaparib versus placebo if they had responded to platinum. So slightly different than the last example. So we have long awaited this trial. It was started in 2017, which is interesting because we didn't hear the reports of SOLO-1 until 2018. So this is actually really a very forward-looking trial. And lo and behold, these are the results. So outside of people who attended ASCO, you are the first to see this. What you're seeing here is that these are again progression-free survival curves that show that over time, the patients that went on to the placebo, that the tumors grew, but in the patients who were on olaparib, they grew at a lower rate. And this applied not only to the BRCA mutation cohort, but also the patients that did not have a mutation in their tumor for BRCA. And there's some other nuances that we can talk about with this particular trial. But again, I just want to emphasize these hazard ratios are below 0.5, which means that there's a potentially 50% reduction. Now, I don't want to say everybody needs to jump out there and start doing this again, but I do think it does raise a number of important hypotheses that we need to consider when we talk about the large number of patients who are receiving PARP in the frontline setting and then are entering up in the recurrent setting with a question as to whether or not they can reuse the PARP. So this was the first of the trials to address that question. Now, the next question that kind of comes up is that if these drugs shrink tumors, is it better than chemo? Now, remember, the data I showed you before were in patients who had use of the drug as kind of a single agent. And so we haven't had many trials that have compared it to chemotherapy. So in this particular trial, they looked at patients who had a germline mutation in BRCA and had had previous platinum exposure and were still considered platinum sensitive, and they randomized them to olaparib, which is the PARP inhibitor, versus these non-platinum chemotherapy regimens. And they were looking for, initially they were looking for progression-free survival, but because olaparib became available during the time of this trial's conduct, it was very hard to get patients to go on to these non-platinum chemotherapies when they could just get olaparib off study. So the trial was then adjusted to be a objective response study. Having said that, what we found was that patients who got olaparib actually had a higher objective response rate than those that got non-platinum chemotherapy, having been platinum. And this was broken down not only by patients that had two lines of therapy, but also in patients who had more lines of therapy after that. So again, reassuring that this is a drug that's active. And to kind of provide some context with this, we call these waterfall because they go downward. This is the best change from the start of treatment. And you can see these lines that go all the way to the bottom are what we call complete responses. And you can see there's more and deeper responses for the patients that got olaparib than they got chemotherapy. So because progression-free survival was one of the original endpoints, this was looked at as well. And you can see how these curves, that if you're on this upper curve, that means it took longer for progression to happen than in the control arm, which again, it was chemotherapy. Again, reassuring. But one of the big questions that comes up is, well, wait a minute, you said these were platinum sensitive patients. In other words, they could respond to retreatment with platinum. How does it compare to platinum? Well, we have a couple trials that looked at this. One is called Ariel 4 and the other is called GY004. And the first one to report was this NRG GY004 trial, which looked at a platinum regimen versus two formulations that included a PARP inhibitor. One was a PARP inhibitor alone, and the other was a PARP inhibitor in combination with another drug targeting angiogenesis called cediranib. And you can see over here on the right that the curves kind of mingle with each other. The blue curve here are the patients who got platinum-based chemotherapy, and the non-chemotherapy arms are here. Now, unfortunately, this did not meet its primary endpoint, which was a difference in progression-free survival, but you can see that there seems to be some activity with these agents. And in fact, if you look at the patients that actually had a germline mutation in BRCA1 or 2, that those patients who actually went on the combination seem to have a better outcome than you might see with chemotherapy alone. And so again, I think this is helpful. Again, this is a subgroup analysis, and I don't want to put too much emphasis on it, but it does raise these new hypotheses as to whether or not we might be able to be as good as platinum-based chemotherapy in this setting of recurrent disease. Now, the newest trial to report is called Ariel 4, and this was actually kind of 2 trials within one, because there was a cohort of patients, and it's a relatively small number of trial, but you can see there's patients that were platinum resistant or partially platinum sensitive who got a non-platinum drug called paclitaxel, which you're familiar with. And there was another cohort of patients who had platinum sensitive disease who got who were included in the study. And in the overall efficacy population, it appeared that the PARP inhibitor was better than the chemotherapy. So some signal there that maybe this is that this again is as good as, or maybe even better than platinum-based chemotherapy, or certainly chemotherapy alone. And this is just to show what those response rates were. So I think we're kind of excited about this because, as we started back here in 2014 with the first approval, which came less than 10 years after it was first discovered, now we have 9 approvals, both in frontline and recurrent settings, and we're continuing to expand upon this because we know that we'd love to either make these drugs work better where they already work. We'd love to be able to come up with a new mechanism to overcome resistance. And we certainly would love to make them put them into our armamentarium, even though we know they wouldn't work. So are there ways to do that? And boy, this field is exploding. We're so fortunate to have all of these new compounds coming back into our clinical domain, where we can start to address some of these new hypotheses of how we can make these drugs work even longer than their normal life cycle. And I'm just going to share with you a couple examples quickly because to close this out. So one was to look at another cell cycle inhibitor or protein called WEE1. This drug, adavosertib, was looked at in a trial that was presented by Shannon Weston at ASCO just a couple months ago. It was looking at patients who either got this is a single agent or in combination with a Niraparib PARP inhibitor, and all these patients had to have prior PARP. Many of these patients had progression on a prior PARP as their immediate prior therapy. So we're really excited to see this particular patient population. And just to give you kind of an overall, no chemo here, the response rates were 20% or better, almost 30% with a combination across all patients. And when we broke this down to those that had a mutation in BRCA genes, you can see it's around 20% response rate. And those that were wild type, almost 30 to 40% response rate. Again, so very exciting. Again, hypothesis generating, small study, but very interesting as a way to extend the life cycle of a PARP inhibitor. And another was to approach another protein that's responsible for that DNA repair. And I showed you another example of that, but this is the ATR protein, which is important in this homologous recombination pathway. Again, a small study presented at ASCO, but I just want to show you that there's excitement because we're starting to see responses in these patients who had a prior PARP inhibitor. So the take-home message is that we have 3 approved PARP inhibitors in multiple different indications. So we're so excited about having that option. The efficacy of this has placed a premium on knowing. So even though we know that everybody should have their BRCA test done at diagnosis, we still see patients who don't have it done. So we are focused on knowing what's going on in the tumor and in the germline so that we can take advantage of these fantastic new drugs. And fortunately, we have a number of new trials now that are ongoing to help us extend, like I said, the life cycle of these drugs, because we think that they can be leveraged in new ways. And there's so many of these projects that are ongoing. And again, knowledge is power. Remember, this is the only way we're going to move the field is that we identify these trials, participate on them, either confirm or refute the hypothesis, and move on so that we can add new things to our armamentarium. So with that, I'll close, and and happy to take questions. Thank you.